Hello, everyone, and welcome to our module on informed consent. All medical interventions that you carry out for patients require what's known as informed consent. And by this, I mean that patients must agree and consent to the treatment, and they must be informed about the benefits of the treatment, the risks of the treatment, and the alternatives to the treatment. So, if you're going to prescribe a medication or perform a surgical operation, you first need to tell the patient about the benefits. And these are usually fairly obvious. They usually will make the patient feel better or become healthier in some manner or another. You also need to tell the patients about the risks of the intervention, and you must describe all major adverse effects. So, for example, for surgery, you need to describe the risks of bleeding or infection. Now, one thing to note is that commonly known risks do not need to be described. For example, when I prescribe medication to my patients, I don't have to tell them that one of the risks is that you may choke on a pill. That's because choking on a pill is considered to be a commonly known risk. I do, however, have to tell them of side effects of the pill, for example, if they might get a rash or develop joint aches or something along these lines. And then finally, you also have to tell them what the alternatives are. What are the other therapies that they could take instead of what I'm recommending? And what would happen with no treatment? This is the third and final component of informed consent, and you have to tell the patient about alternatives. Informed consent must be in a language that the patient can understand. And if the patient does not speak the same language as the physician, which is usually English in the United States, then you must use trained language interpreters. And this often comes up on board exam questions. If the patient does not speak English, you must get a trained interpreter. A family member is not acceptable because you can't be sure that that family member understands English well enough to translate your words properly. If you get a trained language interpreter, then you can be sure that your words will be properly transmitted to the patient. In addition, informed consent has to be voluntary. The patient can't be coerced. And the patient has to have what's known as decision-making capacity. And in a separate video, I talk about how to determine whether or not patients have decision-making capacity. Once a patient gives informed consent, they can withdraw it at any time. So, in a board question, if a patient agrees to a surgery and changes their mind as they're being wheeled into the operating room, this is actually okay for the patient to do. We have to respect their autonomy and allow them to withdraw their consent. Every procedure that you're going to perform on a patient requires its own consent. You cannot presume that consent for one procedure implies consent for another. And the classic example of this is a famous case known as Moore versus Williams. In this case, a non-life-threatening diagnosis was detected in the operating room. The surgeon went in to operate on the right ear and uncovered disease on the left ear. The surgeon then operated on the left ear without specific consent. Afterwards, the patient developed complications related to the left ear surgery and the patient sued and won. The reason the patient won is because the doctor only had consent for operating on the right ear, not on the left. Now, one thing I should point out, emergencies are an exception. So if a patient begins to bleed from their liver during an operation, you can obviously treat them for that. That is an emergency. But if you detect a non-emergent condition like a potential tumor that is slow growing and not immediately fatal in another part of the body, you cannot operate on that when you only have consent for operating in another part of the body. There are some exceptions to the general rule that you need to obtain informed consent before you can treat a patient. And I've listed some of these on this slide here. In another video, I will talk about lack of decision-making capacity, but in this video, we'll talk about these four exceptions to the general rule that you need to obtain informed consent before treating a patient. In the setting of a life-threatening emergency, consent is implied, and the classic example is a trauma victim that is unconscious. This patient obviously cannot give consent, but it is okay to treat them because it is a life-threatening emergency. Now, in the video on decision-making capacity, I talk about how incapacitated patients can have surrogate decision makers like a husband or wife. If that surrogate decision maker is present, then they can weigh in on the therapy, obviously, and they can decline or accept various interventions. But if there is no surrogate decision maker available and the patient is incapacitated and unable to give consent, it is okay to go ahead and treat the patient because consent is implied. Therapeutic privilege is another potential exception to informed consent. Therapeutic privilege refers to the privilege of a treating provider to withhold information when disclosing it to the patient would cause a dangerous psychological threat. This is often invoked for psychiatric patients when completely informing them about their diagnosis and the necessary treatment would put the patient at risk for harm to themselves. Therapeutic privilege is usually invoked only temporarily. Information is withheld until a plan can be put in place with family and other providers. Importantly, therapeutic privilege does not apply to distressing test results. You cannot withhold information about a cancer diagnosis because you think it would upset your patient. In addition, family members cannot ask you to withhold information from a patient to avoid upsetting them. That is not an appropriate use of therapeutic privilege. It's only to be used in a situation where you think information would directly lead to harm to the patient or to others. You also cannot use therapeutic privilege to trick a patient into treatment. For example, if a patient doesn't want to submit to therapy, you can't lie to the patient to get them to agree. If you've watched the video on ethical principles, you know that patient autonomy is the most important guiding principle. You have to respect patients' decisions even if they are different from what you think they should do. And lying to a patient and invoking therapeutic privilege is not an acceptable way to get patients to agree to therapy. A waiver refers to the fact that patients may ask a provider not to disclose risks. In other words, a patient can waive the right to informed consent, and the provider is not required to state the risks of a therapy or a surgery over the patient's objection. Now, in a board exam question, if you're faced with a situation where a patient doesn't want to know the risks of surgery or some other treatment, the right answer is often to try and understand why. You want to make sure the patient has a clear understanding of the surgery, and you want to make sure that they are not asking for a waiver because of a misunderstanding of what is about to happen. Now let's talk about informed consent in minors. So the definition of a minor is usually a person less than 18 years of age. And in this situation, under normal circumstances, only a parent or legal guardian may give consent. So for example, if you have a small child and that child needs treatment for an infection, the parent or legal guardian has to consent. That's the way informed consent is handled for minors. There are a couple of exceptions, however, and these often come up on the boards. And those are emergencies, which we've already discussed, and also emancipated minors, which we'll talk about in a minute, and finally, a couple of special situations. In the case of a life threatening emergency involving a minor, consent is not required. It is implied, like we talked about before, and care can be administered to the minor even if a parent is not present. In addition, in the case of minors, care can be administered in the setting of a life threatening emergency, even against the parent's wishes. The state has an interest in the welfare of children, and parents cannot decline life threatening medical interventions for their child. And the classic example of this is a child whose parents are Jehovah's Witnesses and do not want their child to receive blood products. The physician may administer blood products in the setting of a life threatening emergency to the child, even over the parent's objections. You do not need a court order, and this is because the child is a minor and therefore life threatening interventions are allowed. An emancipated minor refers to the fact that minors can attain what's known as legal adulthood before they turn 18. This applies to some special situations, which include if they are married before the age of 18, if they are serving in the military before 18, or if they are living separately from their parents and managing their own affairs. And minors who are emancipated may give their own consent. So, in a board question, this will be an older teenager who falls into one of these three categories here and wants to give consent for a procedure. It is okay without the parent's permission. Now let's talk about some special situations involving informed consent for minors. Most U.S. states allow minors to consent for certain medical interventions without their parents' consent, and these are listed on this slide. These include contraceptives, prenatal care, treatment for sexually transmitted diseases, and treatment for substance abuse. And the idea behind all four of these here is that if you required parental consent, minors would be less likely to seek care, and that would lead to bad things. So, for example, if minors had to have their parents' approval to get birth control, they would be less likely to seek birth control and there would be more teenage pregnancies. The same is true for prenatal care. If patients had to get parents' consent for prenatal care, they might hide the fact that they are pregnant, and this would lead to bad outcomes for the babies. If minors were afraid to get treatment for STD because they were required to get their parents' consent, then they might not get treated for STDs, and these would spread around the community. And the same is true of substance abuse. Minors don't want to be inhibited from seeking treatment for substance abuse. Abortion for minors is a special situation in the United States. The rules on parental notification vary by state. So whether or not a minor needs parental consent for abortion will depend on whether or not you are practicing in California or Texas or Florida or Missouri. They are very unlikely to ask you about this on the Usmle exam because the requirements vary state to state. One other comment on abortion: providers are not compelled to perform a procedure on a patient just because the patient wants it. So, for example, if a provider is morally opposed to abortion and they have a patient who insists on abortion, that provider does not have to perform the procedure. However, because that provider has a relationship with the patient, they can't simply refuse care. The obligation is for the provider to refer to someone else who will consider the procedure. And this is usually the right answer on a board exam question if you're faced with a patient who wants an abortion but the physician is morally opposed. For the rest of this video, I'm going to talk about some special situations surrounding informed consent. And the first one is organ donation. So brain dead patients are possible organ donors, but in the United States, organ donation must be discussed only by individuals with specialized training. The reason for this is because it's a conflict of interest for a caregiver to request organ donation. For example, if I am taking care of a patient in the ICU who becomes brain dead, and I tell the family that I would like to harvest the organs of their loved one, the family may believe I am giving up on the patient in order to obtain the organs. For this reason, hospitals employ what are known as organ procurement organizations to discuss informed consent with family members of brain dead patients. Often, one of these groups sends a donation coordinator to talk with the family. Sometimes the attending physician will join the donation coordinator, but the key point here is that the attending physician never does this by themselves. In the United States, individuals are assumed not to be organ donors, and this is not the same in every country in the world. In the United States, family consent is generally required in order for a patient to become an organ donor. And importantly, organ donation cards, which many people carry in their wallets, are not enough for a patient to be considered an organ donor. These indicate a preference, but not a final choice, and they are usually not a reason to override a family refusal to donate. If you want to read more about this, there is a nice discussion on it in the AMA Journal of Ethics. But the bottom line here is that most experts agree that an organ donation card alone is not sufficient to override a family that refuses to donate a patient's organs. DNR stands for Do Not Resuscitate. This is a patient request to avoid resuscitative measures. A patient will declare themselves DNR when they mean to decline care in the case of a cardiac arrest. So, for example, they do not want CPR and they do not want electrical shocks to the heart. Now, importantly, just because a patient is DNR, it doesn't mean they can't get other therapies outside of the setting of cardiac arrest. So, other therapies can still be given. This includes ICU care and even surgery. You just cannot give resuscitative measures. And a related status for a patient is called DNI, which stands for Do Not Intubate. This is a patient request to avoid mechanical ventilation. It often goes together with DNR, and many times in the hospital, you will hear it said that a particular patient is DNR DNI. This means that they do not want to be resuscitated and they do not want to be intubated. But once again, other therapies can still be given, including ICU care and many other treatments. Now, when patients become incapacitated, they obviously cannot provide informed consent, and the ideal way to handle this is to do what's known as advanced care planning. This means deciding with the patient about what they want for care prior to incapacitation. Ideally, this is done as an outpatient with the patient's primary care physician. So, for example, if a patient has been seeing Dr. Jones for primary care for decades and decades, ideally, Dr. Jones will talk with that patient at some point in time and write down in the chart what that patient's wishes are in terms of resuscitation, intubation, and other aggressive care measures. Now, many times this doesn't happen, and in that case, it's often done on admission to the hospital. This is especially important for patients with chronic illnesses like heart failure. They're at high risk of becoming very sick in the hospital and then becoming incapacitated. So, on admission, you want to ask them what their wishes for care are so you can document it in the chart. And this is called advanced care planning. So the goals of advanced care planning are to identify and document the patient wishes, things like the DNR DNI status, which is often referred to as the code status. You want to determine whether the patient has a living will or a healthcare proxy, and I talk about these two items in the video on decision-making capacity. And as I mentioned on the last slide, this is very important in patients who have chronic illnesses, things like cancer, heart failure, COPD. Patients with any of these illnesses are at risk of becoming incapacitated, and you want to document ahead of time what their wishes are. Let's talk about research. Research requires consent. All clinical research studies require informed consent. It doesn't matter if the drug or therapy is FDA approved. It doesn't matter if the drug or therapy has no known risks. If a patient is going to participate in a research study, you must inform them about the research study and obtain their informed consent. Most hospitals and medical institutions have what's known as an IRB, which stands for Institutional Review Board. This is a committee that reviews and approves all research studies, and their job is to review the protocols and make sure that there will be adequate protection of human subjects. They balance the risks and benefits, so sometimes research carries a small risk, but there is a big enough benefit that is worth doing, and they also ensure that all patients are going to give informed consent before participating in the research study. Prisoners can participate in research. My own hospital has a large prison ward, and the people on the prison ward can be involved in research studies. However, they have to give their informed consent just like anyone else does. And then finally, financial disclosures are a very important part of research. Many drug and device companies pay for research studies, and this is okay, but you have to inform patients that the industry is sponsoring the study when you obtain their informed consent. Another special situation around informed consent is pregnancy. So, pregnant women may refuse treatment even if the baby's health is impacted. In the United States, a baby is not considered a person until it is born. So, when the baby is still in the mother's womb, she can refuse treatment even if that refusal potentially harms the baby. And this often comes up in board questions. The mother has autonomy over her own body, and until the baby is born, it is considered part of the mother's body. A few words on appropriate documentation of informed consent. So, if you are obtaining consent for a procedure, the person performing the procedure ideally should obtain and document the patient's consent. An alternative is that someone very familiar with the procedure can also obtain consent, even if they are not going to perform the procedure. The way this often comes up in board questions is they describe a scenario where the medical student who doesn't know anything about the surgery is asked to obtain consent. This is not okay. It has to be someone very familiar with the procedure and ideally the person who is going to do the procedure. Now, often patients are asked to sign a form which documents that they've given their informed consent, but importantly, the act of signing is not sufficient for informed consent. Patients still have to be fully informed by the provider and they have to have understanding. And patients have won legal cases despite signing a form because they were able to successfully argue that the provider showed them the form but didn't adequately explain the benefits, risks, and alternatives of the treatment. And lastly, you can obtain consent over the phone. So, for example, if a patient is incapacitated and the healthcare proxy is not available in person, but you can get them on the phone, it is okay to get consent over the phone. The usual rules apply. You have to inform the person over the phone of the benefits, risks, and alternatives. Usually, this is done by getting a witness, which is a second person to get on the phone and hear the consent, and then the provider and the witness together will document the phone consent. And that concludes our video on informed consent.